A 59-year-old man walks into the emergency room, clenching his upper abdomen in severe, unbearable pain. The pain shoots straight through to his back. When he tries to walk or lies down, it gets even worse. Leaning forward gives him a small relief, but the pain is still excruciating. However, it didn't start like this. Just 2 days earlier, it was only a strange feeling of fullness in his belly, with nothing alarming. He thought it was just gas or something he ate, but slowly things began to change. The discomfort turned into pain, the pain kept increasing, then came nausea and repeated vomitings. And by the time he reaches the hospital, this is no longer a mild discomfort, this is a full-blown medical emergency. So the real question is what is happening inside his body that turned a simple feeling of fullness into something that dangerous, and more importantly, what caused it. He has no history of alcohol or drug use, and no previous problem with his liver, stomach, or pancreas. But his medical history tells a different story. He has diabetes, high blood pressure, high cholesterol, and he is overweight. Recently, he also started weight loss injection, and just in 6 months, he lost nearly 20 pounds or about 9 kilograms. Now in the emergency room, the team moves fast. A nurse notices something concerning. The man's heart rate is racing and his blood pressure is low. This means it's not just pain, his body is also unstable. Blood is drawn and rushed to the lab, and a short time later, the results come back. And just like the physical examination, the blood tests are also alarming. His white cell count is elevated, a clear sign of intense inflammation in the body, along with several other abnormalities. But one number stands out more than anything else: lipase. His lipase level is extremely elevated at 847. And when you combine that with his severe abdominal pain, it's points toward one thing: something is seriously wrong with his pancreas. Because lipase is an enzyme produced inside the pancreas, under normal condition it stays there. But when the pancreas is injured, it leaks into the bloodstream and shows in the test. And that's exactly what's happening here. But still, doctors need confirmation, so they order a CT scan. And this time, the images don't leave any doubt. The final diagnosis became clear: acute pancreatitis. Acute pancreatitis is a condition where pancreas becomes severely inflamed, and in more severe cases, it begins damaging itself and even affecting nearby organs. Which means this is not just an abdominal discomfort. Acute pancreatitis is a serious condition and sometimes life-threatening. The man is admitted to the hospital for close monitoring, further treatment, and more importantly, investigation. They act immediately. Supportive treatment is started, IV fluid, strong pain control, and close continuous monitoring. But one question remains unanswered: what did cause acute pancreatitis in this man? The doctors are facing a long list of possible causes. They have to go through them one by one, eliminating each possibility until they uncover the real culprit hiding in the plain sight. The search begins. First, they check for one of the most common causes: gallstone. An ultrasound is done, but there are no gallstones. Next, they consider alcohol, another major cause of pancreatitis, but the patient clearly denies any history of drinking. So they move on. They check his blood lipids. Yes, his cholesterol is elevated, but not high enough to explain something that serious. Other tests follow, but none of them provide a clear answer. And now the case becomes even more puzzling. So the team goes back to the beginning. They slow things down and carefully review one critical detail: his medications. Because sometimes the real answer isn't the disease itself, it is something that the patient has been taking all along. And this patient is now on a GLP-1 agonist, a medication used for type 2 diabetes and weight loss. Recently, his treatment was changed. He switched from Ozempic 1 mg per week to Mounjaro 7.5 mg per week. And shortly after his very first Mounjaro injection, his condition began to worsen. Now the doctors start connecting dots. It is possibly an acute pancreatitis triggered by medication, and in this case, Mounjaro. The man is admitted in the hospital for some days, and things are taking a darker turn. Complications develop. Infection added to inflammation, leading to a condition called infected necrotizing pancreatitis. Doctors added antibiotics to the treatment regimen to avoid further complication, and at first, there is a small sign of hope. He slowly began to improve. But something still isn't right. Even as the pain starts to settle, a new problem appears: a persistent fever. On the 5th day of the admission, the doctor decided to look again. A repeated CT scan is ordered. And this time, the results are worse than anyone expected. The disease has spread, now involving the left side of the colon, There are signs of bubble paralysis. At the base of his lungs, part of lung has collapsed, and fluid has started to collect around his left lung. This is no longer just his pancreas, multiple systems and organs is now involved. But fortunately, after a long, exhausting and difficult hospital stay, he finally stabilizes. Slowly, he recovers enough to go home. He is discharged with strict follow-up under a gastroenterologist, which simply means a gut doctor, and with one important instruction: stop Mounjaro, because in this case, Mounjaro is the main suspect. This drug belongs to a class of medication called GLP-1 receptor agonists, and you have probably heard of them. They are often called miracle drugs for diabetes and weight loss. Celebrities use them, social media praises them, demand is exploding worldwide, but behind all the hype, there is a serious question. Do we truly understand what can happen when powerful medications are started or switched too quickly? GLP-1 receptor agonists like semaglutide, liraglutide, and tirzepatide, which you might know as Ozempic, Wegovy, and Mounjaro, are transforming modern medicine. They work in multiple powerful ways: increasing insulin release, which means lower blood sugar, lowering glucagon, which means lower blood sugar again, slowing down stomach emptying, which means fullness for longer time, and they can even travel to the part of the brain called hypothalamus and suppress appetite there. And that's exactly why they are so effective for type 2 diabetes and obesity. And that's also why many people call them miracle weight loss drugs. And in most cases, they truly are. They help millions of people with type 2 diabetes gain control over their blood sugar, stay healthier, and avoid complications. And for millions others struggling with weight, they offer something that once felt impossible: a real chance to lose weight without surgery, regain confidence, and take back control of their lives. But like all powerful medications, they are not without risk. The most common side effects are well known: nausea, vomiting, diarrhea, and constipation. But there are also rarer, more serious complications like gallbladder disease and pancreatitis. However, pancreatitis is rare, so rare that many doctors may go their entire career without seeing a single case linked to these medications. And if no one is looking specifically at the medication history, the connection can be easily missed. Because when doctors think of pancreatitis, they usually think of something else first. The more common causes of acute pancreatitis, like gallstones, heavy alcohol use, abdominal trauma, or extremely high triglycerides. And this creates a dangerous gap between perception and reality. Because when it comes to GLP-1 medications, science is not completely straightforward. Some large studies and meta-analysis suggest that the overall risk of pancreatitis is low with GLP-1 medication, or even uncertain in some cases. But real-world cases like this tells a more complicated story, because when it does happen, it can be severe. So now new questions start to emerge. Is the risk of pancreatitis with GLP-1 drugs truly uncertain? What happens when patients switch between them? Are we understanding the risk when medications are changed too quickly without proper dose adjustment? And most clinical guidelines are very clear. When switching between GLP-1 drugs, you should restart a low dose and increase it slowly, even if the patient is already on another GLP-1 drug. But in real life, that doesn't always happen. In this case, for example, the patient had been on Ozempic for 6 months without any serious side effects. But when he switched to Mounjaro without proper dose titration, this complication followed. And interestingly, research showed that the more common side effects of this drug are dose dependent, meaning the higher the dose, the more nausea and gastrointestinal symptoms. But rare serious complications like pancreatitis don't always follow a clear dose pattern. And that makes them much harder to predict and much easier to miss. And in real-world practice, that's exactly where problems begin, because they don't follow the textbooks. And acute pancreatitis is not a minor condition. Every year, more than 200,000 people in the United States alone are hospitalized because of it. It usually presents with severe upper abdominal pain, nausea, vomiting, and sometimes fever. To make the diagnosis, doctors typically need at least 2 out of 3 findings: characteristic abdominal pain, elevated lipase levels, and imaging changes in the pancreas. While many cases improve with supportive care, others can take a much more dangerous path. They can progress to sepsis, organ failure, ICU admission, and depending on the severity and underlying cause, death occur in roughly 5 to 25% of cases. So, where does it leave us? On one side, GLP-1 medications are revolutionizing the treatment of diabetes and obesity. They improve blood sugar control, help people lose weight, enhance quality of life, and for many people, they restore confidence, self-esteem, and even mental well-being. And most patients tolerate them very well. But on the other side, there are rare yet serious complications that we still don't fully understand. And sometimes the greatest risk isn't just starting a medication, it's how we switch it. Because in cases like this, the danger may not come from the drug alone, but from how quickly and how aggressively we move from one to another. We put a lot of time and effort into scripting, recording, and editing these videos. If this kind of content helps you even a little, give that like button a gentle hit and subscribe. It really helps us.